What if I slide that further? Is it recording?
It's recording.
Okay. Hypertensive and emergency and eclampsia. So first I'm gonna just do a little case presentation and then we'll talk about like informative stuff about it. So we have a 22-year-old at 37 weeks. She comes to triage and she has severe headache and dizziness. What would you guys do? Tell me, I wanna know like from a nursing perspective, what do you guys do, like the process of when this person comes in to triage? What's the first thing you do?
Vitals.
Check her vitals.
Tox check if she's complaining of that.
Ask about a history, or a pregnancy history.
Okay. Put her on monitor.
Oh, yeah.
Get her urine and stuff like that.
Mm-hmm.
Okay. So you put her on the monitor, check vitals, all that, and this is. Oh, I keep hitting the wrong button. These are her vitals.
Turn her on her side, retake it. In like 15, well, I wait, I would wait 5 or 10 minutes, probably.
Okay.
15 minutes is the most.
And probably get the seizure pads for the bed.
Okay, that's good. Yep. All
And
those
call the
things are
doctor.
good.
Call the doctor.
Would you call the doctor right away? And I'm not asking the question, I'm just,
Yeah.
okay, finding out how you guys respond, okay.
With all those other symptoms, between her blood pressure, her headache and all that, you know.
Yeah,
Um,
and then, so yeah, all that stuff, that's all good. You wanna check the cuff, make sure it's the right size, you know, put them on their left side. If they're on their left side, make sure your cuff is on the right, is on the other arm. Call for help too. You're probably gonna need help. You need all your stuff in the room, your IV and all that. Get your bed pads. And so all those things kind of have to happen at the same time, and you need to be looking at the patient, assessing her. Okay, so that's all good. 5 minutes later, her blood pressure is 208 over 113. She looks at you, says, "I don't feel well," and then she vomits all over you. All over, on top of your IV that you're trying to start. Her eyes roll back, and she starts having a seizure.
check your time.
Good. Yeah, that's one I didn't think of. That's good.
First thing,
See, that's
check
another
her
thing that I
time.
didn't know.
And
Okay.
try to figure out how long it's lasting and try
Yeah.
to keep her safe. You don't want to hold her down or anything like that. You just try to keep her safe.
Right. Right. Yeah, that's good. What else do you do when someone's having a seizure? What's like, basic BLS stuff for a seizure?
Airway.
Yeah,
Airway. Oxygen. Right. Bed rails.
Mm-hmm.
You said turn on
So they better be up.
Yeah.
We got the seizure pads already on her.
Yeah.
so they better
Yes.
be up.
Excellent. And remember, you don't have an IV yet because she just vomited on it. And you want to try not to worry about the baby at this point. You want to resuscitate mom, keep mom safe, make sure she's oxygenating, and try not to worry about the baby just yet. So then after 2 minutes, the patient stops seizing. You're able to start her IV. You only need one. You don't need two. And you start administering your antihypertensives and her mag sulfate bolus. And then you remember your other patient, and you notice that the heart rate is in the 80s.
Well, hopefully the doctor's in there by now. If not, I'm going to call the doctor again.
Okay.
I'm going to make sure I put pulse ox on mom to make sure it's accurate, that it's baby and not mom.
Okay.
Make sure she has oxygen on.
Good. And you guys, that's all good. Yeah, you don't want to freak out about the heart rate in the 80s. That's going to happen. And anytime mom has almost every time a mom has an eclamptic seizure, the heart rate's going to Brady. And so you have to just, wait it out basically, because and you have to calm down and remember that this is normal response and calm the doctor down, because the doctor's probably gonna be like, "Oh, we gotta go to the stat section of the patient." That's not what you do. You just make sure that you resuscitate mom, and then the fetus will resuscitate too. And then, so we have a protocol for our antihypertensive meds. You guys are aware of it. I'm assuming I have it. Okay, well,
I'm not gonna, I need to review it.
yeah, so it's from the ACOG committee opinion that just came out in 2015, and they just copied it directly from that committee opinion, so it's a good protocol. And then we also have our next sulfate protocol too, and so, we start following that at this point. So the first dose that you give, according to our protocol, is 20 milligrams of labetalol IV. So we give her that. And that starts to go in. After 3 minutes, the fetal tracing is now in the 160s. No variability, no ACT cells, occasional variable D cells. And that's the mother's vitals now. So at this point, what should we do?
Oh, it's only been 3 minutes.
Well, this is like 3 minutes after the seizure stops. I don't really.
I guess I was just thinking about repeating the labetalol. But
Yeah,
I
you got in
didn't-
10
I don't,
minutes.
but I don't
In 10
remember.
minutes.
10 minutes?
That's
Okay.
right.
I couldn't remember.
You're absolutely right. So at this point, you could follow our protocol for our second dose of meds once 10 minutes passes. And that's the thing that's important too, is like you want to time when you give the dose and make sure you give them that full 10 minutes because the medicine will start to work. We just have to, it's really hard to be patient in these situations because you just want to fix them right away, but you have to give your medicine time to work because it does work and it will work. And the baby will get better too once mom gets better. So at 10 minutes exactly, you go to your next step of your protocol, which is 40 milligrams of labetalol IV. And you have to give it over 2 minutes.
Okay.
So, and you don't need a cardiac monitor,
It's pulse ox, right?
pulse ox, right? So, yeah, give it time, be patient, try to be calm, talking to your patient, and,
Keep
you
it
know,
quiet, make sure it's quiet and
Yeah.
dark.
and that people are not panicking, the family and all that stuff. And the baby and the mom will respond. So now 10 minutes later, you check again, and these are your vitals. The patient is starting to come around, she's starting to talk to you, her fetal heart rate is looking better, still minimal variability, but she's starting to have some moderate variability too. No ACT cells, no D cells. The doctor tells you to check her cervix. You check her cervix, and it's 370 minus 1 vertex soft and anterior. So what do we do now?
Just keep watching. Just kind of keep watching.
Keep watching.
So her pressures are still elevated.
Her pressures are still elevated, yeah.
We're gonna start an induction probably.
We're probably going to start an induction. Right, so at this point, her pressures are definitely still elevated, but now they are out of the dangerous, severe range where it's considered,
160 over 100, is
hypertensive
it?
emergency. Right, 160 over 110 is considered
110.
hypertensive emergency. So now we've kind of dropped right below that, so you don't have to administer another dose of labetalol right now. You continue checking every 10 minutes, and this is just a case. After I'm done with the case, we'll kind of talk a little bit more about details of what you do step by step. But so at this point, you would start getting more of a history and start making your plan for what we're going to do for delivery, because the only way that we're going to really definitively treat her is by delivering the baby.
Well, they said her cervix is favorable, so.
Yeah, so would you think that an induction would be good at this time, or do you think we would have to do a C-section? Right.
I think we can try for induction.
Yeah, and an induction in an eclamptic patient is reasonable option if they have a good favorable cervix and you think that you can get them delivered within 24 hours.
24 hours.
Yeah. So you want to, at this point, you continue your monitoring her blood pressure by your protocol, because our protocol will, tells you with MAG how often to check their blood pressure within the first hour that they're on MAG, and then after each hour how often you have to check their blood pressure. Since she's eclamptic, you want to put a Foley in this patient because urine output is going to be really, really important to watch. Draw your draw your labs, all that stuff. Now you can do all that stuff now that you've kind of taken care of the emergency.
Now our protocol, I mean, I could wait and read it later, but anywhere I've ever worked, if they were on magnesium for preeclampsia, we automatically had to do a Foley.
That is not on our protocol, but I think it should be. I also agree with that.
Because
that
they were going to want strict INO,
You need
and you
strict
can't do
INO.
strict INO without a Foley.
And I'm gonna talk to the other doctors and talk to Carrie about adding that to our thing. I wrote here. I was like, where's the Foley?
Okay. Oh,
And
okay.
there's such a fall risk too, getting up and down on mag.
Right.
Yeah.
And we'll talk about that a little bit too, because there's also the whole NPO thing about when someone's on mag. All right, so then you start Pitocin, and basically she does fine. She delivers her baby. It's a little bit small, and then she names her baby after you, and you post on Facebook how much you love your job because you saved the baby. Okay, so now we can talk a little bit about just like the details. So this is the definition of hypertensive emergency. So I'm not talking about, obviously this person probably had, preeclampsia and then got eclampsia, but this is just the definition of a hypertensive emergency, and it is when it's greater than 160 over 110, and it's persistent for more than 15 minutes, and then that is considered a hypertensive emergency. Now, I probably wouldn't wait a full 15 minutes to like diagnose, I would. You check it 10 minutes later, you have to, you should start acting at that point. So, your goal at this point is not to have normal blood pressure, your goal is to have mildly elevated blood pressure, because more than likely this baby has had mildly elevated pressure for a long time before she became this, severe range pressure, and if you drop it too low, then the baby's not going to perfuse well. So you want to keep the blood pressures in a mildly elevated range. And studies have shown that institutions with standardized evidence-based clinical guidelines like we have will reduce adverse maternal outcomes. So these are the three treatments, or the three options, and they're basically labetalol option, hydralazine option, or an oral nifedipine option. Ours, and they come straight from this committee opinion, and the one that we have is labetalol. But you can use any of them are good options. So if one doctor prefers hydralazine over labetalol, that's good. The oral nifedipine, supposedly it's just as good. However, I think most of us prefer IV. We feel that it works faster still, and there's not as much studies on it as there is with and not as much use as with labetalol and hydralazine. But it is a good option to remember if you're having trouble getting an IV in the patient. You can give someone an oral dose of nifedipine or even an oral labetalol. So the way it works is you give 20 milligrams IV over 2 minutes, recheck the blood pressure in 10. If it's lower than 160 over 110, you can just monitor. If it's more, then you give the 40. And then the same thing, then you recheck in 10, give 80. Recheck in 10, if it's still above 160 over 180, you switch to hydralazine, and that's 10 milligrams IV. Repeat again, check in 20 minutes this time with the hydralazine. If it's still up, that's when you want to consider that the patient may need a central line and need a drip, like either a hydralazine or a labetalol drip. The medicines do work, and they will work. You just have to be patient and wait and give them those full time. And it does. I don't think. I think I've seen like 1 or 2 patients that have gotten to the point where they needed to be on a drip, where it's not responding like that. So, and remember, we're also giving them MAG at the same time.
A 6 gram bolus?
6 gram bolus, yeah. So, medication side effects to labetalol, neonatal bradycardia. You don't want to give it to an asthmatic because it'll bring on an asthma attack. Hydralazine causes more like sudden hypotension. And nifedipine can have that reflex tachycardia and then hypotension and a headache. And then, like I said, if you're having trouble starting the IV, you can always do 200 milligram oral labetalol until you get their IV started, and then or the nifedipine, which is I think 10 milligrams PO. And then we have our magnesium sulfate administration. We have this clear policy here that you guys can look at. The only, like I said, I do feel like some stuff is missing from it with the Foley, and watching the urine output is not in this part with the assessment, and that's very, very, very important. So you want to make sure you have all your equipment in the room, and that includes your calcium gluconate for mag toxicity. Whenever you're administering mag, whenever a patient is on mag, you should have your calcium gluconate in the room. So you want to give your 6 gram bolus. Oh, explain the side effects to your patient. That was a nice thing that was in here that I wouldn't have thought about. But tell them that they might feel hot and have flushing and feel dizzy and get a headache, all those things. Infuse your 6 gram bolus over 20 minutes and don't leave the patient's bedside. And monitor your mom and baby according to the policy. And we can copy it and you guys can look at it. So monitoring them, meaning their vitals, their fetal heart tones, TOCO, DTRs, level of consciousness, listen to their lungs, and get their urine output. So then after the after the bolus goes in, then you start your 2 grams per hour continuous infusion. Some doctors use 1 gram per hour, some use 3 grams per hour, it kind of depends, but standard is start at 2 grams per hour, and then you can increase or decrease depending on if the patient is starting to look, like a little bit toxic. You can decrease your dose to 1 gram per hour. If they continue to seize, you can increase your dose to 3 grams per hour.
And you're running this with like a maintenance fluid too, like LR, right?
Oh,
Yes, and that is something that you have to look at, because I don't know that part, but I think so. But the maintenance fluid should be pretty low, right?
Usually
Oh,
it
okay.
equals
it
my
equals
trade.
125 an hour.
Yeah, that's in here too. If your urine output drops below, this is why you need to have a Foley in, because I don't know how you can measure it that accurately like the other way, but if your urine output drops below 100 in 4 hours, you need to probably lower the dose, the maintenance dose, because that could be a sign that they're starting to have some renal impairment. And then if they have renal impairment, that increases their chance of mag toxicity, so that's why you have to lower it. And pulmonary edema too. You guys know the signs of mag toxicity and pulmonary edema?
Mm-hmm.
Lethargic,
Yeah,
slurred speech.
yeah, altered mental status.
Question, a lot of times they'll complain about having trouble breathing.
Mm-hmm.
Shortness of breath.
Yeah. And then if you suspect it, that's when you draw your mag level. And you give your calcium gluconate only if the person is showing signs of cardiopulmonary compromise. At this point, if something like this is happening, you need to have the doctor needs to be in the room. So absent DTRs, they will have decreased DTRs when they are on mag, but absent DTRs is a sign of toxicity also. And then pulmonary edema, shortness of breath, chest tightness, coughing, they have a drop in their O2 sats, they have diminished breath sounds, and then they just feel really, really anxious. So like we talked about in the case, once the hypertensive emergency is under control, then that's when you move to like figure out how you're going to get this patient delivered, because that's the only way. And if the patient is really, really bad where you can't get them under control, they may need to be placed on a drip and then transferred out of here. So, but yeah, the ultimate goal is always delivery in someone who has either severe persistent hypertension or eclampsia. So now we'll talk about eclampsia briefly. The definition of eclampsia is a new onset generalized tonic-clonic seizures in a woman with preeclampsia. It occurs in only 2 to 3% of women who have already severe features of preeclampsia. There is about 10 cases per 10,000 deliveries. It occurs in preterm infants in 50% of the cases. 40% of the time it occurs in antepartum patients. 20 to 30 occurs in intrapartum, 10% less than 48 hours postpartum, and 5% occur greater than 48 hours postpartum. Have you guys ever seen somebody have an eclamptic seizure? No? Have you seen a seizure ever? Somebody have a seizure? Like a grand mal tonic-clonic seizure, that's the kind of seizure that they have, so it looks the same as anybody else having a seizure. They will for several hours before usually have some signs like severe headache, they'll just have like this periorbital edema, tons of swelling, they feel horrible, they'll just keep saying, I don't feel good, I don't feel good, usually, sometimes it just comes out of nowhere, but visual disturbances, seeing spots, right uppercardum pain, those are all signs that you have an impending seizure coming. The few that I have seen, the patient will have that severe headache. I haven't seen an eclamptic person without a severe headache. But I read somewhere that it's only about 80% that actually have a severe headache. And then this thing that I was reading said that they'll have an abrupt loss of consciousness, and then it's associated with a scream or a shriek. I haven't seen that, but then their muscles in their arms and legs, they become stiff. The woman may appear cyanotic, which is why the baby gets bradycardic. After about a minute, usually, then it becomes the clonic phase, and that's where they do like the jerking and twitching. And that's where they can bite their tongue, lose bladder control, etc. Then after that, so it's usually pretty brief, but it feels like forever when it's happening. Then after that is the postictal phase, and then they're just like out. It's like they're in a really, really heavy sleep. So field bradycardia, it's almost always present during and after the seizure, and it can last 3 to 5 minutes, with the recovery after that even more, where they'll become, just like when they have bradycardia during labor, they'll get that reflex tachycardia and then be flat. They do the exact same thing when they've had a seizure. So they'll have that reflex tachycardia, loss of variability, and then transient decelerations. They can be lates, they can be variables, and then you just have to make yourself wait and remember that once mom is resuscitated, the baby will resuscitate too. And you don't want to run to the OR to do a stat section. That doesn't really help the baby when you're delivering. You want to wait for the baby to recover in utero, then hand the baby hand the pediatricians a birth baby.
How long do you give it time?
So that's what we'll talk about. If a non-reassuring pattern with frequent recurrent deceleration is present for more than 15, it's actually 15 to 20 minutes, but most people don't like to wait more than 15 minutes, but in the literature it says 15 to 20 minutes. Despite resuscitation, you want to be suspicious that there's something else going on. It's usually an abruption. But if your baby looks okay before they start seizing, and then it looks like crap after they start seizing, then you just need to wait. It'll get better once the baby's better. So if you witness a seizure, we talked about it during the case, roll her on her left side, maintain her airway, prevent aspiration, prevent trauma and hypoxia. That's how you want to protect your mom. Then the next thing is treating her severe hypertension with the medications we talked about and prevent recurrent seizures, and then make your delivery plan. So that's what you have to do for an eclamptic patient. If you have someone with persistent seizures on maintenance mag, it's very, very rare to have someone keep seizing once they've already gotten their bolus and their mag. But if it happens again, you can increase their rate to 3 grams per hour, or even 4 grams per hour, and you can also do another bolus over 5 to 10 minutes, a 2-gram bolus, with frequent monitoring for mag toxicity. If they're still not controlled, you may consider administering benzos. But at that point, you probably are consulting like a neurologist or something to help you out, and hopefully transferring from here. But I guess you can't really transfer someone while they're seizing. You need to get that under control first. And then prompt delivery. This is the only way that you're going to treat this patient. A lot of people want to just go straight to C-section because they know it's going to be fast and treat the patient very quickly. But if they have a favorable cervix or a multip or something, and the fetal status is reassuring, it's okay to induce. You don't want to induce someone with a closed, thick, and long cervix, and it's going to take 3 days. That's not of any benefit. So you just have to kind of make that decision. Oh, I also forgot to mention, I don't remember where I had this, but if you can't get an IV and the patient is seizing, or for whatever reason you're having difficulty getting an IV, you can also do mag IM. You can do 5 grams IM in each buttock. And
So 10 total.
10 total gram. It takes longer to kick in, but you can administer your mag levels that way. If someone is, it's just something to keep in
Do
your
we have
Yeah,
that
arsenal.
available?
I don't know,
Readily
that's a good
available?
question. That's something that we need to ask. I just need a pen. Yeah, that's a good question, we can ask about the IM mag. I'm sure we can probably get it.
We would just
Wow.
need to make sure it's here on our unit
Yeah.
for in case something
In
like
case
happens
emergency.
between 11 to 7 at night.
Yeah,
Because we don't have pharmacy here.
yeah.
So then that's the AR.
Yeah, that is something that we should have,
Mhm.
available. Because sometimes you can't get IVs on these people. And if they just keep seizing, at least you can hold them down and give them a
Right.
mag. Postpartum care, they almost always resolve after delivery, pretty quickly. And this is another reason why you need to have a Foley in these people. The best way to know if a preeclamptic patient or an eclamptic patient is getting better is if they're diuresing. If they are not diuresing, they are probably still going to have, pretty bad disease. But once they start pouring out that fluid, then you know that they're going to get better. And you want to keep that patient on magnesium if they're eclamptic for 24 to 48 hours. The regular preeclamptics that haven't had a seizure, it's 24 hours, but sometimes these patients need to be on for longer. And the decision of when to stop their mag, you just have to kind of look at them and see how they're responding. If their blood pressures are quickly getting better after delivery, if they're pouring out the urine, their labs are starting to normalize, you can probably stop in, 24 hours. You want to keep that strict isonose and keep the patient NPO even until they have been seizure free for 12 to 24 hours. And we keep them NPO because they're a seizure risk and they can aspirate. So when I was a resident, we trained if someone is on mag, they have a Foley in their NPO because the reason that they're on mag is because you think they might have a seizure. So they're a seizure risk and an aspiration risk. But a lot of times people will let them eat postpartum. But really, if they are a true eclamptic that they seize, they probably should be NPO. And that's it. That's the whole thing. Any questions?
Yeah.